Welcome back to the Woven Well podcast. Today we're going to talk about somewhat of a secret weapon in the reproductive health and fertility world, and that is low dose naltrexone. Have you ever heard of it? If not, you are not alone. Over the last decade or so, there's been some interesting uses of it, specifically some off label uses that have become a game changer for women dealing with PMS, endometriosis, autoimmune issues, all sorts of things. But who is it for? How could it benefit them? How should it be used? These are really important questions. And so I invited Ashley Jensen to talk us through it. Ashley is very experienced in its use as she's been a Creighton model system nurse midwife, trained in NaProTechnology, FEM, Fertility, and she is serving women and couples through the University of Utah and has been for many years. So Ashley, welcome to the show.
Thanks, Caitlin. It's a pleasure to be here, and I definitely geek and nerd out about this stuff all the time. So, yeah, thanks.
Absolutely. I was just telling somebody before recording this that I dream about this stuff all the time. So it's on my mind even when I go to sleep. Well, will you tell us a little bit about yourself and the work that you do?
Yeah, I've been working for about 6 years, and all I do is restorative reproductive medicine. I'm assuming your listeners know what that is, and that's all I do. So even though I'm a nurse midwife, I don't deliver. So I'm basically a nurse practitioner, and this is all I do, and I eat it, breathe it, drink it. It's how I live it. I live it too. So, but I love it, and I do some of the infertility work, but I would say by and large, I'm doing more GYN stuff now than infertility. Kind of just naturally switched to that over the last couple of years as patients have just sought me out and do a lot of PCOS, PMDD, which we'll talk about that with LDN. Very helpful for that. So,
Yeah.
but yeah, so this is my life. So happy to be here.
And that's very helpful too to hear that you're working in gynecology specifically because maybe sometimes we do put a little more emphasis on the infertility side of
Mm-hmm.
things because there's so much that we can offer those
Yeah,
struggling with infertility. But this applies to everyone.
totally.
Any woman can benefit from this restorative reproductive medicine. Doesn't matter if they're single or trying to conceive or trying to avoid pregnancy. If anyone dealing with these reproductive health issues can benefit from it. So let's talk about low dose naltrexone. What is it? How does it work? Let's get into it.
Yeah, yeah. So naltrexone originally was made is FDA approved for opioid withdrawal. So you'll definitely get some looks for people that when they only know the FDA intended purpose for it. But when used in a low dose form, so it's about 10% strength of the standard FDA approved dosage of 4.5 milligrams, it works in an entirely different way. You still don't want to be on opioids when you're on it, but it has a lot different mechanism of action. So it's used a lot, accepted pretty widely in the functional medicine world. So I would say most functional medicine providers are going to be pretty familiar with it, or naturopathic providers. There's actually some books out there called like the LDN book and the LDN book 2, where they talk about its use in a lot of those autoimmune conditions. So things like multiple sclerosis, Hashimoto's, lupus, Crohn's, fibromyalgia, things like that. As far as functional meds, acceptance of it, thoughts about using it in like the GYN world is not as broad. So they don't necessarily like readily think about it for some of the conditions we'll talk about today. But it does help modulate your immune system, which is why it's used in the autoimmune world. And the way I usually explain it to people for a lot of the conditions that we use it for is that one thing that we know it does is increase your beta endorphin levels. And the way it does that, it's typically used at night. You have endorphin increase at night. I mean, you have endorphin typically like pretty steady, but it will cause a temporary suppression of the beta endorphin level. And in the morning, it will cause a subsequent rise, and then it'll actually cause your body to make a higher amount than what it would have been making before. So patients that benefit from it are like, yeah, it's a good fit. Typically, they have that noticeable improvement in well-being. From those endorphin levels. So like I mentioned, the immune modulator can help decrease inflammatory cytokines, chemical messengers that are promoting inflammation, keeping the immune system in check. So from the immune side, that's why it's very, very more broadly used or known for its use in the inflammatory side of things. I actually learned while I was researching for this that I can actually help with like PCOS on the insulin side of things, which I didn't know. So that was
That's,
new
I think that's a
information for me.
newer, I
Yeah.
think that's a newer use. I've only had one or two clients who've used it for insulin resistance. And so when they first told me about it, I was like, oh, tell me more. And I've been looking into it since. But yeah, this low dose has a lot to do with reducing
Hmm.
inflammation.
Hmm.
And I appreciate you specifying how it works with increasing the beta endorphins. And I can imagine how that could make you feel better and could
Hmm.
reduce inflammation. How can it help women with gynecological issues, though?
Yeah, so I would say like one of my biggest, like the red flag, I don't know, maybe a green flag, like I think you'd be a good fit for this. When patients, I'm doing their history, especially on a new intake, the things that I think, hey, you'd be a great candidate for trying naltrexone, would be PMDD in general, so premenstrual dysphoric disorders, that extreme PMS. Automatically, I mean, I've had just really really good success with that. Those patients do typically end up on higher doses than the standard low dose 4.5. Most of my patients in that PMDD category do much better around like 6 to 10. I have one gal, she's been on 10 for a long time, doing really really well, which we can talk about her. She's one of my favorite patients. And then pretty much anytime like PMS, if they say they have anger or rage, this is actually a pretty like uh, widely accepted in the NaPro world. That's one of the things Dr. Hilger's trained with NaPro, is that rage piece, that anger rage piece. And so I've been pretty in tune to that. So when I am going over the PMS list for patients, like, okay, do you have irritability or do you have anger? Okay, is that anger? Would you say that you have like mom rage, or if they're a mom, or like just rage where you're just like, I just can't control myself? If they say yes, they're more on the anger side than the irritability side, then I'm like, I think this would be a really good fit. And it really does help with that symptom. Um, Other things that I've, on the GYN side would be like interstitial cystitis, which is, I would say any age can have it. I've had young patients, I've had older patients, perimenopausal patients, postmenopausal patients. So it's not defined to any age. But interstitial cystitis is basically when a woman thinks she has a UTI constantly, but keeps getting it checked and it's not. So you just have this like kind of vague bladder, urinary pain. And then I see this a lot be kind of almost cyclical in nature, where they're experiencing this like only around their period, only around ovulation. Sometimes we think it may be linked to that endometriosis piece a bit, but I've had patients respond really well where that symptom just entirely goes away when they're on LDN, which is really helpful. Long haul COVID has really benefited from it, especially that like chronic fatigue piece of the long haul COVID has been really great. Endometriosis has been awesome. So there's a lot of different things, but I would say those are like my big like, hey, like I think you'd be a good choice. I'm gonna recommend this to you now versus later. There's other things on the fertility side that I'm like, hey, well, we could give this a try. It might help your fertility, and maybe it might not help symptom wise, which was, I think, for me was the case, but I didn't really notice anything really changing about it. But I got pregnant. It was great. But other patients do really notice like huge improvements in some of those side effects and those bothersome things.
Mm. So, are there particular, you were talking about in the infertility side of it as well. Are there particular candidates that are dealing with infertility, like certain things that it can improve, or is it just sort of a general overall if somebody's struggling with infertility?
Yeah, no, there still definitely is markers, particularly like Hashimoto's. If a patient has Hashimoto's thyroiditis, like with those elevated antibodies, it's very helpful for reducing that antibody load, which we know is helpful because of its benefit on that inflammatory, helping on the immune modulation side of things. It's really helpful on that. With endometriosis, we do know that, like I said, from that work that was done through Pope Paul VI Institute and Dr. Hilgers' work, we do know that statistically, women with endometriosis and PMS have statistically significant reduced levels of beta endorphins, which this is the endorphin specifically that LDN is helping with. Like I would say, like this would be my example. Like I had endometriosis, I had surgery for endometriosis. I went on LDN. I really could not say that I noticed anything positively beneficial, like side symptom wise. But
Mhm.
like based on those studies, I likely had reduced beta endorphin levels. So we know that if we put a patient with those reduced beta endorphins on LDN, it's going to increase those endorphin levels, which um, we think are going to be helpful in just your overall body function. And then on the inflammatory side, we do think that endometriosis is a kind of inflammatory, it's, I would say it's still not well understood. The term I kind of use with patients is that you kind of with endometriosis get this unhappy pelvis. So okay, there's not anatomical obstructions, but there's something that's making your pelvis be like, yeah, we don't want to make a pregnancy here. So I'll help
Mhm.
on the unhappy pelvis and kind of just calm things down and hopefully allow for that conception and implantation.
Yeah, and I think the commonality between almost everything that you're talking about is inflammation. And you can talk to a lot of medical professionals out there and they will tell you that inflammation in many ways is a threat to overall health. Now, obviously, our bodies need inflammation. We can use inflammation to our benefit. There are certain ways that is absolutely essential, but when it's overdone or in areas that it's not necessarily supposed to be, that's a lot of times when we also notice those autoimmune issues where certain parts of the body are responding negatively to the healthy, normal function. So Hashimoto's
Mm-hmm.
is the body rejecting a thyroid function that is natural and healthy. And so we get that response. Now, the interesting one to me is the PMDD because we can treat PMS through supporting the post peak or luteal phase progesterone production. And in my experience, that usually takes care of PMS symptoms if they're long or severe. But then there's PMDD, which is
Mm-hmm.
more that brain body connection. And so it's like the brain is misfiring or responding in a way that it's not intended to the drop in progesterone and estrogen right before the period. And so I find it really interesting that LDN is a great fit for that because it makes sense. Supporting the beta endorphins is going to help the brain not misfire, but understand like, hey, this is normal, this is okay, this is
Mm-hmm.
healthy. And I've actually had a good number of clients over the years who had PMS, got that treated, felt so much better. And there are a lot of lifestyle things and
Sure.
dietary things that you can do to help your progesterone levels as well. But there was still that missing piece, but they didn't want to go on an SSRI
Mm-hmm.
for whatever reason. Like
Mm-hmm.
they just didn't want to do that. And so to have an option like LDN that works totally differently, I think is a really great avenue for a lot of people. Listeners, by the way, if this is helpful information, if you find this interesting or helpful, if you want to pass it along to someone else, then what I want you to do is take 5 seconds to leave a review. It makes such a difference to listeners getting episodes like these out to other ladies who are looking for more resources, and your quick review can help us to do that. So, actually, when we're thinking about results to expect, maybe even timelines, like what have you seen in your patients over the years?
Yeah, typically we tell people it takes at least 6 weeks to get to kind of that effective, you can actually judge this is what it's going to be for you. It is something you take every day. So thinking about that PMS, PMDD, you're not just taking it during your premenstrual phase. And then you can say, okay, how do I feel? We usually ask, do you feel better, worse, or the same? If you feel worse, that's probably not a good fit for you. And that is the case, that it is not the magic bullet for everyone. I'd like it to be, but some patients just don't tolerate it. Um, I've, it's generally tolerated well. The most common side effects that people explain or experience would be vivid dreams. And the category that I would say is not a good candidate typically for this are patients with PTSD trauma. I've had several of them that have had really severe PTSD nightmares.
Mm,
As a result of it. I've had some of
yeah.
them like, hey, let's maybe try doing it in the morning. They've done a little bit better. We know that the mechanism of action isn't going to be quite as good in the morning, but I'm like, hey, we could give it a try. But typically, those vivid dreams, usually not too bad. Usually, if it's a good effect, for you. It's a medication that's going to help you. That usually goes away. Most patients say they'll sleep better. It can feel kind of like jittery or wired initially. I rarely hear that. Headaches have been mm, moderately common. And then nausea can happen. But typically that one, if you just increase your dose, we usually increase slowly over time. If you're just slowly increasing, if you got some nausea, just increase it a little more slowly and your body usually gets used to it. And then we usually get to that 4.5. And then at the end of 6 weeks of being on 4.5, then we say, hey, better, worse, or the same. If you're worse, probably shouldn't be on it. If you're better, great, let's stay on that for now. If it's about the same, then let's try increasing, and we increase by 1.5 increments. They'll get to some dose where they'll be like, oh, I felt better at the last dose. Let's go back to that. And so that's where kind of they figure out where their sweet spot is. And then maybe they're good there for a while. And then after, 3 to 6 months, you're like, I think I need an increase. And the nice thing about it, if you do compounded, is you can make those adjustments yourself, which is really nice.
Mm. Well, and I know we're running short on time, but I'm curious, are there things that you can do while you're taking LDN to try to improve the beta endorphins, like so that you don't have to be on this medication long term?
That's a good question.
Yeah,
I
it's
would
okay if you don't
say
know.
it depends on what we're looking at, what we're treating. Um, PMS, for example, PMDD is a different beast, like you mentioned, but PMS, typically is like low progesterone. Well, if you have low progesterone, it's probably because you don't have a great ovulation. Well, if you don't have a great ovulation, there's probably a reason. Is it, metabolic insulin resistance? Is it thyroid that you need balanced? Is it, vitamin D that you need more of, and those things that are going to help facilitate better ovulation, therefore going to facilitate better progesterone levels. So I think there's always that like look back, and we're always in restorative reproductive medicine trying to get to that root cause. And so I think that sometimes it is a little bit of a band-aid, like, hey, let's be on it for now, but let's try to like fix these underlying things. Like I said, PMDD seems to be a little bit different thing. And so I think that it's a little bit harder to adjust with that, but yeah.
Yeah, and that's a good point too, that you're going to be treated in that holistic manner. You're looking at the whole person, the whole body. And so it could be that as those other things are getting treated, then you could experience no longer needing the
Right.
LDN as time goes on too, which is of course important. So
Right.
thank you so much for being on the show, Ashley, and sharing with us.
Yeah, of course. That went by really fast.
Listeners, many time in the midst of reproductive health issues, we can feel like we are on our own as women to get them addressed. Issues that often go unnoticed deserve to be investigated, diagnosed, and treated. LDN may be a part of that journey for you, but it's obviously not for everyone. So if you'd like to learn more about LDN, look for research on its use in restorative reproductive medicine. As always, thanks for listening as we continue to explore together what it means to be woven well.